Good afternoon, everyone. Thank you, AIOC2023 and Dr. Maheshwari for giving this opportunity. Today I am going to talk about minimum invasive glaucoma surgery in Indian perspective. As all we know, we start the glaucoma treatment as usually the medical and laser treatment, then proceed for the primary for surgery like tube and trabeculectomy. But there is a wide gap between the safety profile like medical and laser to the surgery. So here the MIGS come and play the role. MIGS is the gap between the laser therapy versus the surgery. So if you look at the current trend, the MIGS is going to be probably the next area. The MIGS will be the first choice of surgery. Why MIGS is going to be popular? Because it's safety profile, less traumatic, and connecting the anti-chamber direct to the outer rectal chamber. So these are the various device-based MIGS are available. We talk about the India, only few device-based MIGS are available like istent. When we come to the TM-based MIGS like GATT, bang, and trabeculectomy is easily, readily available in India. So we look for this economy, really the istent and ADB really not cost effective for a country like India. So these are the some MIGS like GATT, microtrabeculectomy, bang, ADB are easily, readily we can do. So these are the various surgery easily we can perform in India, and it really have the little learning curve. So before starting any kind of MIGS, one surgeon has to be incompetent in the good intraocular gonioscopy. That's the first thing you have to learn, and it doesn't require much thing. Just you need the right gonioscope and that your microscope should do it. And never any time you have to learn, you have to try first. If you want to learn intraocular gonioscopy, then you start your any kind of surgery. So first I will come to the gonioscopic assisted transluminant trabeculectomy, Scott and GATT. This is 2014, first started by the Garova and Fallman et al. In this procedure, originally the canal has been fed by the microcatheter. Later on, they changed the fibroprolene suture. So what the indication? These are the common indications for any kind of MIGS. The primary opening glaucoma, mild to moderate stage without cataract, and even a secondary glaucoma you can do in the all stage. Until this is not the vision threatening, visual field having the vision threatening things. So these are the instruments required for the GATT. You need fibroprolene suture, microtying forceps, low temperature pottery. Rest everything is routinely available in our OR. So this the video is showing how to perform the GATT. So first of all, we have to learn, this is the instrument we talk about, in positioning of the microscope. So we have to tilt your microscope 35 degrees toward yourself and keep the patient head away from you 35 degrees. So this is the perfect position to look for the angle, direct visualization of the angle. Then put the viscoelastic and dock the lens. Once we dock the lens, we can have the beautiful image of the angles. And here we put it magnified. In GATT process, we are just blunting the tip with low temperature cautery and form that AC with cohesive viscoelastic, and again look the angle. And this is straight determined with the goniotomy. A goniotomy you can do with MBR knife or you can do with 25 gauge needle. And this goniotomy side, just we have to thread suture, and really we need the 18 to 20 strokes are required to get the distal end. Once you see the distal end, just if you grab the distal end and this proximal end here to go, you can take it out. So another this is single case, another the second case with the silconoid. So clear the silconoid first, make the fibroprolene proline tip bend and make a goniotomy. Sometimes you get the unexpected reflex, you just clear it and again proceed the same. So I'm going to this another video. Recently we have started with the GATT into the PACG cases also. So this is to keep in mind. Once you master the POAG cases, then only jump into the PACG cases, because identifying angle is a little challenging with the PACG cases. So once you identify the correct angle position, you can easily perform the GATT in PACG cases. So this is, but there's a little difference will be there because here the resistance will be more in compared to the POAG cases. And really sometimes you feel at the end when it stroke, it's 50, sometimes 20 to 22 strokes are required. Really you feel resistance when the distal end is coming. And really if you feel distant, then you can understand it's in your correct position. And see that now the distal end has been came out. So similar way, just you have to pull it out. Once you pull out, there's a lot of reflex will be there. You need to clear the blood reflex viscoelastic and keep your chamber little bit tighter while you are closing the anterior chamber and wash it thoroughly. There should be no blood at the end of the surgery. So now coming to the second thing is called quick dual plate. In this method, the plate is being used to introduce into the sledge canal, and this device is flipped and stretch the trabecular muscle. So I am showing this video. It's a quick dual plate. Similar way, we just have to make the anterior chamber, and this is the animation in which the plate is going into the sledge canal, stretching the trabecular muscle, cutting and stretching. It should be done 30 degrees from the right hand side. Similar way, other 30 degrees from the other side. So this is the way. And only thing such instrument when you are doing the first time, you have the blade in hand. Sometimes the left hand should be well controlled because sometimes you just press the too much pressure applied into the by left hand because your hand lens is holding. Sometimes you get the corneal folds. So that has to be managed nicely. And sometimes we get when you're doing this procedure, your blades, you have to be able to see the blade under the trabecular muscle. That means you are not too much into the sledge canal. You are not disturbing the inner tissue of the inner part of the sledge canal. And once it's done, you can see nicely exposed posterior wall of the sledge canal, and at the end of just clear the lens. So what we can do in India like country, because screening is current 14,000, is the company recommended one single use, but we can use up to the 4 times. We use up to the 4 times saying the good results are there. So how to make it? This is simple 25 gauge difference, right? I will show you the video. So 25 gauge dip, just dip initial part of the dip, you have to bend it. Similarly, here the only thing we have to take care because the little end is very sharp, so we have to take care. We should not surround. We should not damage the surrounding tissue. So take this needle, and the needle tip always should be in your eye. This should not go away from your eye because once you go, it can damage the iris down and behind the sledge canal also. And sometimes you get this tissue has been come out, then you can clear by the microforce. You can clear it. Then coming to this is the right choice of procedure called the microtherapy. This is a Sinski kind of instrument, and by this instrument you can treat the more than 240 degree of the angles. And this is a quite simple procedure. This instrument you can, after phacoemulsion, you take the instrument through the side board, and this side board you just cleavaging the trabecular muscle. Just cleavaging and opening you can see the nice opening of this trabecular muscle, the posterior wall of the muscle you can see nicely. And this procedure, we can do first complete the temporal side, then you sit into the temporal side, and you can sit the temporal side, you complete the nasal angle, and sit to the nasal side and complete the other side of the angle. So it's a quite good procedure. You can do in a different case scenario. I'm not showing it. Then coming to the finally the eye stent. So eye stent is wonderful stent. It is very small stent used in the eye. I think it's a large number of this eye stent is used in the eye. It's called the eye stent. It's making the right communication between the anterior chamber and the outer collector chamber. So we have the long history of the eye stent. It's using more than 15 years. We have different kind of eye stent inject, eye stent W, and the various like hanger study and not showing the good outcome over a period of 5 years. So this is just video. I just have showing you how to do the eye stent. So similar way, just lock the lens, see the angle. When you're doing the eye stent, you see always in the high mag, go the magnification up to 1 or 1.5 to identify this eye stent coming the preloaded in the probe. 2 eye stent will be there in eye stent, and just you have to go and push it to the trabecular muscle and push the button in the probe. The eye stent is delivered. This is a good sign when you get the blood reflex by putting the eye stent to be a perfectly correct position in the sledge canal. When reflex comes, remove the reflex with this plastic, check it, and then proper position is there or not. Then go for the another side, just 30 degree away from 30 degree or at least 2 clock away from it. Put the second eye stent and just tap it. When you're tapping it, that means you're fixing it. It's a perfectly positioned in the eye. And really it is have shown good. The only problem this stent is the cost. is a huge cost, costing around 95,000. So coming to the MIGS complication, they are infrequent and mostly are transient. Most common complication is a high FEMA and maybe the elevated IOP. And sometimes in the learning phase, we can have the decimal member detachment, and some of the bank kind of procedure, we can have the coaches anemia. So MIGS combined with GATT strategy provide the safe new option for the IV reduction. MIGS will become the first ethical choice for glaucoma management, where the GDD and the trap can be reserved for the difficult or complicated cases. Thank you for listening.